Go. We are now recording. So thank you so much, everyone, for coming along to our Heart Health Club Tea with the Experts webinar. We created this Heart Health Club as a way to be able to provide support to those who've been impacted by or at risk of heart disease, whether it's themselves or their families or their carers and so on. Our Heart Health Club offers peer connection with others we have a private Facebook group where you can share how you're feeling and connect with others who may be going through a similar thing. And we also share regular content and these webinars to help improve the heart health literacy of the community. Today's webinar is something I am so incredibly passionate about. Anyone who's been watching our Facebook page over the last few weeks will see how excited I am about this. And I cannot tell you how fortunate we are to have these two incredibly amazing women join us today. Dr. Monique Watts is a heart failure cardiologist and specialist in women's heart disease who works at the Epworth and Alfred hospitals in Victoria. She recently established a cardiac clinic in North Central Victoria to improve access to specialist care for rural citizens, and has also led the development of the Women's Heart Clinic at the Alfred Hospital, which offers specialised care for patients suffering cardiac conditions more commonly seen in women. This is one of Australia's first women's only heart clinics. Dr. Watts is actively involved in clinical research with multiple current projects in progress in the area of women's heart disease. And she also teaches for the University of Melbourne Clinical School. We're so grateful to have you here, Monique.
Thank you.
Alison Daddo became one of Australia's most recognised and loved faces after bursting onto the modelling scene at the age of just 16. She worked with large brands such as Coca-Cola and Portman's and was definitely the face of my childhood and was on the cover of what seemed like every magazine that existed. One year she was on the cover of Dolly 7 times and was voted among the top most influential women of the century by Clio readers. As well as being a qualified birth coach and teacher, Ali is also a screenwriter, producer, and podcaster, co-hosting a brilliant podcast called Separate Bathrooms with her husband, Cameron, which I highly recommend everybody listening to. It's fantastic. Whilst teaching and co-hosting her podcast, Alison has also written and recently published her amazing book, Queen Menopause. This is a book that she wishes she had when she was approaching menopause. And if you haven't as yet read this book, please buy it now and read it. You will not regret it. It is absolutely brilliant. Ali, you have written a book you must be so incredibly proud of. Menopause is just so much more than just your period stopping, and your book adds just such a refreshing and real point of view to it. And I love that it's not a medical book, but it's just this raw and honest account that I'm sure so many women are able to relate to.
Thank you so much. That's quite the introduction.
Honestly, I've been singing you both of your praises since you all agreed to do it. So I'm just so grateful to have you here. I think one of the first things I'm going to jump into, which is a bit of a something that I get a little bit of a bee in my bonnet about, and it's something that you spoke about so incredibly beautifully in your book, Ali, is the absolute honesty with how you shared how your body changed through menopause. So in terms of the weight gain and the absolute utter lack of control that you had over it. And I love the way that you focus on encouraging women to just embrace these changes. They're out of your control. And I think that was just such a refreshing and beautiful thing for women to hear, because I think in contrast to that, I seem to be hearing these stories. We have women messaging us daily where they've been to their GP. And there was just an example yesterday on a Facebook group that I follow. There was a girl who was in perimenopause, which is why she'd gone to the doctor. Whilst she'd put on weight, she was still in a healthy weight range. She'd had a blood test, all her bloods were fine, and yet this doctor said to her she should only eat 1.5 meals a day as a way to sort of manage her weight. And a recent study, which I've read this morning, says there are 45% of women who have cancelled or postponed a recent doctor's appointment because they wanted to wait until they lost a couple of kilos. So I just, for me, I think for both of you, I think this is such an important point. You know, how do we let women embrace this change that menopause brings them whilst being heart healthy and not shaming these poor women when they have no control over this?
Yeah, I was actually really fortunate. I was just online yesterday with a menopause specialist in Melbourne, and she really went in and talked about the weight gain that women go through perimenopause and menopause. And we're actually meant to gain a little bit of weight. This is like, when she actually said that, I was like, what? No one told me that. That with the estrogen dropping, it does cause the belly to grow a little bit. Now, of course, from what I also understand, I was listening to a nutritionist just before, and I know Monique will have so much more information about this. You don't want the belly to grow beyond a point where it's unhealthy, because then I know that that puts you at risk for certain things, including heart disease, from what I understand. And again, Monique will explain that better. But I think this is what we're up against as women in society. We're constantly up against what social media says is the sexy look, how to be thinner, how to lose take a pill and lose the menopause belly. I mean, it's just constant. I get it on my Instagram constantly, like, because I have menopause, I think in my bio, I am constantly getting these ads for how to lose the menopause belly. Like, it's over and over and over again. And look, it is challenging when you see your body change without having changed your diet or your exercise routine. It's sort of like, well, how did this happen? Often seemingly overnight, which it did for me. But it forced me to really go, well, what's the important thing? Am I actually healthy? And if I am answering yes to that, then I just go, this is my new shape. This is what I need to work with and love and be okay with. But I know there is a flip side to that, and meaning there is an unhealthy weight gain as well that may show other issues. So, but yeah, look, I think that's something that as women we're just up against all the time. But not just women over 40. It's young girls. Like, it's from the minute we become, the minute we get our periods, it's like we're measured against this ideal of what a body should look like, and it's some of us are born with bigger hips. We'll never have the body of some influencers that are like born with tiny wee hips. We won't ever get there, but we're meant to somehow. So it's painful, to be constantly compared to what should be. But so yeah, I'm very much about being able to just feel healthy in your body and just accepting what you have.
Yeah, and in terms of so I know that there's a lot of talk, Monique, about measuring waist circumference and monitoring your weight daily. As Ali says, how different is it to do that versus just we have a nutritionist with the Heart Health Club who has actually just done an article for us in terms of nutrition with menopause, and she says you need to do, and which is also actually highlighted in your book, Ali, is just focusing on fresh fruits and vegetables, whole grains, high protein. That's the sort of stuff you should focus on, and cutting out alcohol and smoking and highly refined foods and sugars is actually going to worsen your symptoms anyway. But how important, Monique, do you think is that number on the scales for?
Look, I think it's pretty soul destroying waking up each morning and stepping on the scales. I mean, I don't think it's helpful for anybody. I think it's a really important point to focus on what are we actually trying to achieve. And often it is looking to achieve a healthy blood pressure, or achieve a healthy amount of exercise, or achieve a healthy cholesterol profile. So sure, women's risk of heart disease increases at the time of menopause, and that occurs at the same time as there is a change in body fat distribution. And yeah, there is an association between waist-hip ratio and risk, but I think it's more important to focus on, okay, what can I actually do to improve my lifestyle to make me more healthy? And I think that if you focus on, 30 minutes of exercise 5 days a week, brisk walking, not just dawdling along. If you work at, fruit and vegetables, increasing fish in your diet, minimizing those saturated fats, looking at sustainable changes to behavior, as opposed to starving yourself to try and get a number down, you'll be in a better place in your head. You're more likely to succeed. You'll feel better about yourself, and it's more sustainable. Yeah. So I'm not a big fan of weighing my patients at all, because it's really hard. And as you say, a lot of it at the time of menopause is beyond your control, and there are so many things going on. I think it's more about educating women about what they can do and empowering them to say, okay, this is where I'm at. What do I need to do to assess my risk, and what can I do to reduce it?
Yeah, that's great. I think so. In terms of, so obviously there has been a focus in the past that, you know, everyone thinks if you've got heart disease, you kind of gave it to yourself because you put on weight. How important versus, so you've got your weight gain, which people seem to keep talking about and thinking about, but how much more important for women in particular is their obstetric health and telling their current GP what they went through when they were pregnant, no matter how long ago it was?
Yeah, so when we look at risk for heart disease, we look at traditional risk factors, which are the risk factors that we've identified through mainly studying men, to be perfectly honest. Most of our trials in cardiology have been done on men. So we've established that smoking, diabetes, sedentary lifestyle, high cholesterol, high blood pressure, all put you at risk of heart disease. What we're learning through research that we're now starting to do in women is that women have their own set of female-specific risk factors. So things such as obstetric complications, so preeclampsia, gestational diabetes, preterm delivery, all put women at much higher risk of heart disease at a younger age. Similarly, that endogenous estrogen that we're all talking about, that natural estrogen that we have, is really protective against heart disease. So early menopause also increases a woman's risk. Okay, so it's important for women to know this and to be aware, because not all GPs will be aware of this necessarily. This is sort of new information that we're getting. So women need to go, you know, even if they don't have high blood pressure and they don't have diabetes, they may still have other risk factors. So there is so much more to cardiac risk than the way you look and about your weight. And a lot of it is beyond your control. You know, a lot of this is genetically determined, you know, whether you've got preeclampsia or whether you've got diabetes may have nothing to do with the way you've behaved. And that's something that I see a lot of, particularly in my female patients, is this shame. I've got this bloke's disease, and how did I end up with this? There's
What
nothing
did I
feminine.
do?
Yeah, what did I do wrong? There's nothing feminine about having heart disease,
Yeah.
but we need to change that, because it's one of the biggest killers of Australian women. And we just need to be more loud and proud about it, and learn about it, and empower women to embrace it and embrace their risk and do what they can to minimize it and get the help that they need.
Yeah. And I think when it tends to be, you know, women tend to get, if they get heart disease, it tends to be post-menopause. You also talk in your book, Ali, about the kind of shame that people have about menopause. So you throw in the shame that people are feeling about menopause for feeling older, the shame that they're feeling for having put on weight, which is, again, potentially out of their control, and then a shame for developing heart disease. So it's one of the reasons why we're here today having this webinar, because it's just such a pet passion of mine and for our organisation to make sure we fund a lot of female researchers, because we are so passionate about trying to change this dialogue. Yeah,
that's great. And then you add to the fact that you know, most women I know, and speaking on behalf of myself, I just, you push through so many things. You ignore symptoms so much. And we're raised in a culture, again, where, you know, we've had our periods since the age of 12, 13, and you deal with period cramps every month. So you're sort of used to this kind of, oh, I'm going to have pain each month somehow or another. And so we push through a lot of things as women, I feel like, and we're so used to taking care of other people that, you know, when it comes to menopause, and of course now we're talking about heart disease, that if that's all wrapped up in this idea of shame and self-care, and we're not doing enough for ourselves, then, you know, it's a real issue that we need to change, and more women need to be looking in on themselves and seeing what is actually going on inside our bodies, and without the shame.
Yeah, absolutely. So in terms of sort of saying, Monique, you said early menopause is a higher risk. Are people who say got their period when they were younger, Ali, are they more likely to develop early menopause, or are they, Monique, at a higher risk for developing heart disease? And at what age, when you say early menopause or getting their periods early, at what age do we classify as early?
Do you want to talk, Ali?
Well, as far as I know, and you might know something different, Monique, getting your period early does not mean you'll get menopause early. As far as I understand, there's no connection with that. Sometimes women who have children later in life sometimes get menopause later, because they're still producing a lot of the hormones, you know, that's gone into making babies and stuff like that. That seems to somehow connect. But yeah, as far as I know, that's not related. early menopause, the average age is around 45 for menopause. So anything earlier than that. I spoke to a lady the other day who went into menopause at 35. And so that's early, and she knew it was early. And I actually said, you have a webinar that you need to come and listen. I hope she's listening today.
I hope she came along.
Yeah. So that's what I understand. Do you know anything else about that, Monique?
So that's important. It's actually a dose-dependent relationship. And what I mean by that is the earlier menopause, the higher your risk. Okay. So menopause at 35, that's something you should be talking to your doctors about and saying, you know, what do we do to reduce my cardiac risk? With regards to the early periods, then yes, so there is interesting, it's all observational data, but we've seen by looking at women who've had heart disease, going back and seeing when they first started getting their periods, girls who had their periods earlier, so around less than 12 or more than 15, tend to have higher risk of heart disease. We don't fully understand why this is. It's purely observational at the moment, but it's an interesting thing. We call it a J-point curve. So, you know, getting your period around 13 or 14 seems to be protective. Later than 15, earlier than 12 tends to be higher risk. And again, this is something that is interesting to us as cardiologists. We can say, well, you know, how old were you when you started getting your periods? And if they say, well, I was actually very young, I was 10 or I was 11, then you go, okay, well, potentially you're at higher risk. So we need to look into your risk more closely and see what modifiable risk factors we can address. So there are some risk factors that are not modifiable, such as when you get your periods, whether you had pregnancy complications or when you have menopause. But the modifiable risk factors are the things that we can change, such as your blood pressure and your cholesterol, your level of activity and things like that. I think it's a good opportunity to, if I can, just mention about the different presentations with heart disease. We're talking about pushing through pain and knowing what's normal and what's not and what to expect with menopause. Women tend to present differently when they have their heart attacks. So men classically get the central chest pain you all see on the movies. Women still often present with chest pain, but it might be more of a tightness or a discomfort, or often women say it felt like their bra was too tight. And it's more of a pressure, or it might go into their jaw or into their arms, or just arm heaviness. So they can have very different symptoms, or they may have chest pain, but they've got distracting symptoms such as nausea or dizziness or overwhelming fatigue, that when they do present to the doctor, the chest pain kind of gets ignored, or perhaps the focus is not put on the chest pain that should be. So women present very differently when they have a heart attack. And I think it's important for women to know that chest pain and arm pain or jaw pain or tightness, none of those are normal symptoms of menopause. And it's important to get these things investigated in a timely fashion, because if you do have a heart attack and if you do block off one of your arteries, you've got to get to the hospital quickly so that we can unblock that artery and restore blood supply quickly to the heart muscle so that the muscle doesn't die.
Yeah, that's very, very important. For that's one of the things that all the cardiologists who work with always say is time is muscle. It's like the longer you leave it, the more damage you're likely to have. So you've got to go and get treatment. But see, how do these women, again, the amount of messages I hear daily from women who have presented at emergency and complaining of these sort of random symptoms, and they've been kept waiting, they've been told they have anxiety, they've been sort of brushed away. At what point, if someone feels that something, I know my body and something is definitely not right and something, you know, needs to be done, what sort of things should people be asked for and saying? I've actually got someone who messaged me and said that her doctor said to her, if you go to hospital, make it up and just say, call out every single heart attack symptom so that they actually look at you properly, because she had been dismissed previously. So, you know, we obviously don't want people doing that, but what is there something in particular that these women should ask for if they feel like they're getting brushed off?
Yeah, so look, you're right. This is a problem, and you know there are always exceptions. But statistically, women delay presenting to hospital. So we're scared of going to hospital. We're scared we're going to be brushed off, or we're scared that we're going to be wasting people's time. I hear this all of the time. So we present later. Okay, so that's the first problem. And the second problem is that heart disease is often not picked up. It's missed because it presents differently, because people aren't expecting women to have heart disease, because this is still it's still a picture that we're trying to change. People have still got this idea, people being doctors as well, have still got this idea that heart disease is a men's disease. So women turn up and it's not the first thing that doctors think about. So I think you've got to be really clear. You've got to advocate for yourself. and say, I'm worried I'm worried I'm having a heart attack, and I know that the symptoms can be atypical, or I believe I'm at risk of heart disease. How can we be sure I'm not having a heart attack? And there are tests that can be done. There's an ECG and there's a blood test called a troponin. And most times if you present with chest pain or symptoms suggestive of that, or you raise concern, could I be having a heart attack? Those tests will be done. Now, if those tests are reassuring, then we can be comfortable that you're not having a heart attack. Doesn't mean your risk shouldn't be addressed as an outpatient down the track, and that's something to talk to your GP about. But in the heat of the moment, when you're in the emergency department, they're the two tests that need to happen, the troponin and the ECG, and they'll determine whether you're having a heart attack or not.
I think there's going to be so many women who'll find that really helpful, because I've had so many people say, what do I do? What do I ask for? And I'm sort of like, I'm not sure, I'll find out. So that's a really helpful piece of advice there. Thank you. You were saying that women can tend to present with different symptoms. Can women's heart attacks, can they actually experience a heart attack differently to men?
Yeah, it's really fascinating. So it's not just the presentation and the risk factors that are different, but the actual biology and pathophysiology. So the way a heart attack happens in a woman can often be very, very different. When men have heart attacks, they tend to have a blocked artery. So there are three main arteries that supply the heart and muscle with blood, and a heart attack is when one of those is blocked. So the artery is blocked, the troponin's elevated, the ECG is abnormal. They go for an angiogram, which is when they put the dye in through the arteries and take x-rays. We see that the artery is blocked, we put a stent in, and then there's very clear management pathway of medications and rehabilitation. When women have their heart attacks, they have the abnormal troponin, they'll have the ECG changes potentially. And then when they go to angiogram, there's often no blockage. So everybody kind of goes, huh? Was it a false positive? And often that diagnosis of heart attack is actually retracted, which is really damaging for women to sort of go, well, what happened? And they're often not then put on treatment. What we know from huge studies that have been done in the US on women's heart disease is that women are more likely to have a condition called MNOCA. So myocardial infarction, which is a heart attack, with non-obstructive coronary artery disease. So the arteries are still open, but you still had a heart attack. And you say, well, how is that possible? There are multiple different mechanisms by which that can happen. One of them is that the artery actually spasms down transiently to restrict blood supply, which causes the pain and the abnormalities in the blood. But then they open up again, just in time for the angiogram usually, so it all looks normal. It's always the way. Or it could be that a little bit of the plaque flicked off and then went distal down the vessel. So they've had multiple small heart attacks that aren't able to be seen on the angiogram, but still cause the damage. Or it might be that there's a tear in the artery wall that's really difficult to see at the time of the angiogram. So women are more likely to have this different subset of conditions called MNOCA that still have a negative prognosis. So, patients, this is still dangerous conditions and they still need treatment, but they perhaps need a little bit more working out and thinking about what the appropriate treatment is, because the different causes have got different management.
Yeah. So I know we're talking a lot about menopause and the impact of menopause on heart disease, but there are still women, just because someone hasn't gone through menopause doesn't mean that they can't be impacted by heart disease. We have an incredibly beautiful ambassador who was only 36 years old and was still at the time of breastfeeding her children and experienced a heart attack, thought she just had mastitis because she was still breastfeeding. And it was actually, which is another reason why I said earlier, it's important for your partners to watch this. It was actually her husband who said, I think you could be having a heart attack. And she was like, what are you talking about? Like, I'm only 36. I'm not going to have a heart attack. And it was only because he was a police officer, knew all the signs and symptoms and took her to hospital. But again, like you say, she was saying, oh, I don't want to waste anyone's time. Didn't want to call an ambulance. So her husband drove her, but she had a spontaneous coronary artery dissection, so scan.
Yeah, so that's the tear in the artery wall that we were mentioning. And that can happen to women postmenopause, but it's also the most common cause of heart attack, pregnant women. Now, it's still rare in pregnant women. Most pregnant women won't have this, but if a pregnant woman or woman within the first few weeks to months postpartum is having a heart attack, then that's something that we think about. And we do see it. And there is always this awful story about, didn't even think about heart attack. They told me when I got to the emergency department, I had postnatal depression or I was anxious. Or there's always these terrible stories about this uncertainty, but it's a real thing. And the more we look for it, the more we see it. I think the fact that the troponin blood test is now a lot more sensitive than it used to be, we're probably finding more of them than we used to find. I think in the past, a lot of women were probably sent home. But we're diagnosing more now and learning more about it. It's still a condition that we've got to learn so much more about, but it's an important thing to realize that you can have a heart attack at any age.
Yeah, and you don't just have to have been through menopause. That's something I want to kind of, because we are talking so much about it in this webinar, I want to really highlight that. Something, Ali, which you mentioned in your book beautifully, again, you were talking a lot about sort of anxiety and depression, and a lot of the things that people say before they experience a heart attack is they have this kind of impending sense of doom, and they're like, they know something's wrong and they trust in their body. This is what a lot of men say, and then they go to the hospital. But something that you spoke about in your book was that you would lie awake at night. I think you said your example was the fact that you live in Sydney and that your children were going to be eaten by a crocodile or alligator or something, and that you would lie awake in bed at night just thinking about this. And so I think when you've already gone through all of the changes of menopause and you've got the anxiety, you're feeling a little bit down, or you've got clinical depression, you've got this, sense of doom, how is someone to kind of differentiate the way that they're feeling emotionally through menopause, and then not, maybe this is a question for both of you, at what point do they go, all right, this is more than just menopausal sort of thoughts, this is something more serious?
Yeah, great. My question to Monique as well. I mean, I ended up at hospital because
your sound's a little bit crackly. I'm not sure if it's
oh, is it still crackly?
a little bit. Is it just your mic? Is it?
Doing anything? Crackly on it's crackly on my end.
Monique, crackly on your end too?
Yeah, you're crackly here.
Yeah.
Not what I do. I want to give. I to the speakers on the computer.
Yep, maybe while you do that, we've actually got a question from someone who's watching who said, well, you were talking earlier, Monique, about the troponin levels and the tests for somebody to ask for. Can those tests show a previous heart attack?
So the troponin tends to stay in the body, depending on how high the levels are, they tend to stay in the body for maybe 1 to 2 weeks, but no, they're a biomarker that's released by the heart muscle when there's damage, and then it will go down, and it can go down over days, but usually it wouldn't last around in the body for more than a week. Now, some older patients with certain conditions can have chronically elevated troponins that are just mildly elevated the whole time, and that's not a heart attack. A heart attack is where the troponin level goes up and then comes down again. But no, to look at it for an old heart attack, so, months or years ago, you would generally need to have an ultrasound. It's called an echocardiogram, an ultrasound of the heart, which would show you whether part of the muscle wasn't moving properly. Now, if you've just had a mild heart attack, that might also be normal. So it can be very difficult to tell if you've had a small heart attack in the past.
Ali, we got you back?
Does that sound better now?
Oh, yeah.
I can't believe I fixed it. I'm like the worst tech person.
I'm so impressed. Well, you keep it clearer than it was before. It's brilliant.
That's so good. That's so good. Yeah, what I was saying is that would be my number one question for Monique, actually, because as I was saying, I presented at the hospital with heart palpitations. I had severe tightness in my chest, and it was, but this was during, when I felt, my anxiety was at such a high level with going through menopause, and I wasn't sleeping. And so I guess my question is that with all the anxiety and the lack of sleep that you might experience as a perimenopausal or menopausal woman, and perhaps even the depression, does that take a toll on your heart, and can that actually cause a heart attack, other than the actual, the artery issue, but that amount of anxiety and that high cortisol levels that we're often dealing with, that the panic feeling, and where the heart beats out of your chest in the middle of the night, like, is that actually damaging to the heart, or is that just something we can go, relax, it's just part of anxiety?
I think for the most part we can say relax.
Okay.
However, there is a type of heart attack that is caused classically by emotional trauma or high amounts of stress. And when I say high amounts of stress, that can be different for everybody. But there's a type of heart attack called it's broken heart syndrome, or it's technically called a Takotsubo cardiomyopathy, which is a Japanese word for I think it's octopus catcher, because the heart balloons out at the end, and that's what an octopus cage looks like. Anyway, it's a stress-induced cardiomyopathy. It's classically seen in postmenopausal women. In fact, it's almost exclusively seen in postmenopausal women. So again, this is a fascinating condition. Hardly ever happens to men, seen only very rarely in premenopausal women, and it's triggered by intense emotional distress. And with this, again, there'll be symptoms of some sort. There'll be troponin elevation, ECG changes, and then at angiogram, the arteries are all normal. And again, everybody says, well, what happened? And in that particular case, it's the ultrasound that gives us the particular pattern of the heart moving that says, this looks like a Takotsubo cardiomyopathy. And with time, they will heal. Okay, so usually 6 to 8 weeks down the track, the echocardiogram will go back to normal. Okay, and it actually holds a very good prognosis in the longer term. But it's a real thing. The trickier thing to determine is, does long-term stress also damage the heart? And we know that stress is related to inflammation levels. We know that stress means that people don't look after themselves as well. So I think we could absolutely make an argument that chronic levels of stress are not good for you. Now, you know, if you've got anxiety, if you've got depression, it can be really difficult to sort out your symptoms. But I think the key is that chest pain, jaw pain, arm discomfort, epigastric tightness, none of those things should be ignored. Okay, because you don't want to be sitting at home having a heart attack, and that feeling of something's not right, I don't think that should be ignored. Now, yeah, you have that all the time when you've got anxiety, no doubt about it, but that still a doctor should still be helping you work through that. But a lot of women say, I just knew that something was really wrong, and that's something that shouldn't be ignored.
Yeah. That's a great answer. Thank you. So we talk a lot about, we've spoken about early menopause. What about, so people who have had medically induced menopause? So say somebody has had to go through cancer treatment or so on, and these are often really, really young women. Sorry, not always really young women, but I'm talking about women who say are 35 and they have had medically induced menopause. Do they have a higher risk of heart disease, or is it normal? Or because I know the symptoms, I think you were saying in your book, Ellie, the symptoms for these women are much worse because it happens so fast, so quickly.
That's my understanding, yeah, that everyone who I've spoken to that's had medically induced menopause, it said it's so hard. It's going from 0 to 100 within almost a week. And the symptoms, you know, at least mostly the symptoms kind of sneak up on you, you know, one bit at a time and until you're at a crescendo. But from the women I've spoken to, they've said it's really can be really rough, and it's often harder to get help when like HRT does help. I know a lot of times, but even I've spoken to women that even that hasn't been able to assist them because it's come on in such a rush. So I don't know about that, if that increases the issue for heart disease, or I'm not sure.
Yeah, definitely. So medically induced menopause is something that we should absolutely be helping women with in terms of HRT, because we do think that reduces the risk in that situation. Now, the question about HRT in other situations is a big discussion, and we can go there if you would like to, but certainly with premature menopause and medically induced menopause particularly, that's where, yes, risk of heart disease is increased. Okay, it's a real thing, as is, you know, trouble with bone health and things like that. But that's why we always make sure, well, we should be addressing the role of HRT in those women and making sure that they are looked after and educated. And there's not always time to make plans and things in these situations. Often it's, you know, it's all in a hurry, but it's certainly something that we should be doing. And hopefully, you know, we've got access to that kind of special, you know, those sort of specialists in Australia.
Yeah. And Aboriginal and Torres Strait Islanders, I know that their medical advice is for them to get heart health checks a lot early. I think at around 30 or 35 versus for everyone else, I think it's around 45. That's because they've got a high risk, or?
Yeah, absolutely. So First Nations people have got a higher risk of heart disease, higher incidence of diabetes. So we really need to start screening at a younger age and seeing whether there are things, again, looking for modifiable risk factors. We can't change the genetics, but we can address things such as cholesterol, blood pressure, lifestyle to try and do what we can to minimize that risk. And, you know, often, well, I think traditionally what's happened is we've been waiting for symptoms. So we wait for symptoms to occur, and then we go looking at what can we do to minimize things. But I think there's a huge opportunity for preventative health in heart disease everywhere. You know, women are classically, we're all worried about bikini health. So, you know, we do our pap smears and we do our mammograms, and we're very good at preventative health in that regard, but not so much in terms of heart disease. But I think heart disease, you know, should really be on the radar of, you know, yes, have your pap smear, have your mammogram, but have your cholesterol checked, have your blood sugar level checked, make sure you don't have diabetes, have your cholesterol checked, because you don't feel a high blood pressure and you don't feel a high cholesterol. So you feel fine and you look fine, but these things can be doing damage to you internally that you don't know about.
Do you think, though, that the reason why a lot of women may put back that heart health check is because they know that more than likely their doctor's going to weigh them and just say, oh, you need to lose weight? And, you know, no woman, I don't think I know any women who actually need to be told that they've put on weight.
Yeah. Look, hopefully not. But, you know, it's something that we all need to, I guess, work on and be aware of. And maybe we need to work at educating our women more to say, okay, well, you know, despite what the doctor's saying, you know that there is more to heart health than what you look like and what you weigh.
They can absolutely say, you can go to, I just want to say to all the women, you can go to your GP and say, you don't need to weigh me, that's fine, I want my blood pressure checked. And because there's also studies that show that women are less likely to have their blood pressure checked than men at the GP appointment, versus men are less likely to be weighed than women are. So I think that's just, it also comes down to, as what we're doing here, exactly, educating women so that they have the knowledge to say to their GP, you know, I don't feel comfortable with that, I don't need you to weigh me, I'm eating healthy, I'm doing this, and just focusing on that. Is there any, so I think one of the conscious things I don't want to do here is I don't want to have women walking away going, oh my gosh, well, you know, I've got every niggly pain. And, you know, you mentioned in your book, Ali, oh, just another thing to add to the many, you know, list of ailments that I've got. You know, I don't want people to walk away feeling, oh, I should be, you know, doing this, I should be doing that. Is it more just eat healthy, exercise? And if you have experienced gestational diabetes or something like that in your pregnancy, or if you have a family history. So when we talk family history, is it, at what point is it extended family? Is it immediate family? What sort of?
So it tends to be immediate family. So we're really interested in parents and siblings, and it's heart disease young. So, you know, heart disease in an 80-year-old mother, it's probably not unexpected. But if you've got a mother or father who had bypass surgery or stents in their 50s, then that's premature.
Yeah.
So that's the kind of thing that we're really interested in. Or somebody comes to you and, you know, 3 of their brothers have all had bypass surgery at 50 and their patient 62. You think, okay, well, we need to do something here. I think something that women can do is they can go to their doctor and say, I want a heart health check, please. And that way, those things have got to be addressed. It's not just going to be your weight, but it's going to be, and it should be things like your obstetric history, and your family history, and your smoking history, and, you know, your blood sugar level. So women have a much higher risk of heart disease if they smoke than men. Women have a much higher risk of heart disease if they're diabetic than men. So different risk factors have got different potency as well, I guess. So yeah, there's so much to assess and address beyond just weight. And I don't know, I'd encourage women, try not to be fearful of that.
Yeah. So I think without scaring everyone, it's just get your heart health check, get your risk assessed, and then park that, and then focus on the alligators at night instead. So we've actually got a question from someone who says that they were told both their parents were, I was told that despite both their parents dying from heart disease and having a lot of cardiac symptoms, that nothing came up on a stress test, and they were told that they were okay. They're an ultra runner, they're over 55, and they were told that, so because they were over 55 and an ultra runner, the chance of having heart problem was unlikely, but they've also been told they have a leaky AV valve. I'm assuming.
Yeah, that's okay. I know what that is. Yeah, that's okay.
Yeah, but it was incidental and nothing to be concerned about.
Yeah, okay. So the role of a stress test is to tell us whether you need an angiogram or not. So a stress test assesses whether the heart muscle is getting enough blood at exercise, at peak exercise, which is when the heart muscle is working its hardest because it's trying to pump blood all around the body. So if you've got a narrowing in your artery that's usually more than 70%, you'll usually have an abnormal stress test. You'll get symptoms, the ECG changes will occur, and when they do the ultrasound of your heart at the end of the stress test, it'll be abnormal. The thing to know is that you can have a 50% blockage or even a 60% blockage in all three vessels and have a normal stress test. Okay, now that's important to know because you don't need to have a nasty blockage in order to have a heart attack. You just need to have a bit flick off at the wrong time. So yes, if you have a stress test and it's normal, that is reassuring, but it doesn't mean you don't have heart disease. So there are other tests that can be done to assess for minor disease. And one of those is called a calcium score. So it's not Medicare rebatable, so GPs can order it. It's just a CAT scan that's done of your chest that tells us how much calcium is in the heart. Now, there should be none, but if you've got atherosclerosis or plaque buildup in your arteries, which is what causes heart attacks, you will have calcification. And the more calcium you have, the higher risk of heart disease. So that's a test that you can go and say, you know, I'd like to know what my risk of heart disease is. Do I have any heart disease? And the calcium score will give us an answer. So I think the combination of a calcium score and a stress echo, it's very helpful. But a stress echo alone is reassuring. And perhaps if you had some chest pain or if you had some symptoms, then you do a stress test to make sure there's no narrowings. And that's very reassuring. You can say, look, your symptoms are probably not, you know, related to you having angina or having a heart attack. That's fine. But in terms of ongoing risk and how hard we should be pushing cholesterol management and blood pressure management and things like that, that's where the calcium score is really helpful.
This person said their calcium score was 0.
Perfect. Well, in that case, they are in good shape.
Okay.
And they probably don't need to worry too much. Lifestyle, you know, being fit and watching your cholesterol and your blood pressure is good, but you've probably got another 5 years before you need to worry about repeating your calcium score.
Yeah. Ali, you are so honest in your book and you go through everything that you've been through, but if you were able to talk to someone who's between the ages, say 40, 45 now, before they're sort of hitting this sort of cyclone that feels like it's coming our way, what would you say to that person to kind of prepare them or to just help them go through it and not be too fearful of what's coming their way?
Yeah. Look, I think there's so many things that you can do. I mean, firstly is just read up on what menopause and perimenopause is. The thing I tell everyone to do, which I didn't do because I didn't know, but you know, now had I been able to turn back time, is to have a list. If you're already having your symptoms, definitely write those symptoms down. What are the symptoms that bother you the most? And go get a full blood workup at your doctor, and that's going to show, you know, where your cholesterol levels are, where are your vitamin D, where all you might be out of balance with things, and that'll give you a good sort of health look. And then at the same time, you can get your heart checked, which is amazing. Like put those two together, and what a great experience for you to know really where you are at health wise. But really, it's just being able to, God, if you can just change your mindset about taking care of. Change your mindset about taking care of yourself, and it's easier said than done. And you know, we're often told constantly, you know, you need to self-care, but figuring out what self-care really is for you,
and it differs for everybody.
It's different for everyone. Exactly. You know, some people might think it's a massage once a week, which is great, you know, but it's really about, you know, what am I putting in my body? You know, am I smoking? Am I drinking too much? Where are my stress levels? Because if you're able to go into perimenopause with a healthy body and a healthy mind, the risk of you having bigger symptoms is dramatic. I know if you're exhausted, your adrenals are shot, it's absolutely going to affect how far your crazy hormones take you. So yeah, getting yourself in a good health place is so important as you enter those years. And, you know, because some women say, I'm only 30, you know, I don't need to be thinking about menopause. It's like, yeah, you don't, but you do need to be thinking about those later years and going into it in a healthy way.
Yeah, I think it's more about creating better habits in you younger, so that when you do get into those years, it's natural that you're naturally grabbing for an apple or, you know, the healthier choices.
Yeah.
Monique, I've got a few more questions for you, sorry. So someone said if that her doctor has said, despite, you know, having a lot of the risk factors and so on, that her doctor has said she doesn't need a heart test, and you have to have tick the boxes to be able to get a heart test, and she doesn't. Should she just find a new GP?
Okay, so this is the Medicare rebate for a heart health check is 45. You've got to be 45 or younger if you're First Nations. But any GP can do a blood pressure, a cholesterol, talk to you about your obstetric history, find out your family history. So I would argue that you're never too young to have a heart health check. I mean, great, have a heart health check and find out that everything's fine. But every now and again, we find really high cholesterol. We recently did a study at the Alfred on women who'd had pregnancy complications, and these were all women who thought they were healthy and fine. And the number of high cholesterol and high blood pressure that we found that wasn't diagnosed was astounding.
Wow.
So, I know, absolutely go and see someone and yeah, have the cardiac risk assessed. It doesn't have to be calcium scores and stress tests. It can be blood pressure, cholesterol, lifestyle, alcohol, smoking, all of those things.
Yeah. And if someone has hypertrophic cardiomyopathy, can they still have a calcium score test?
They can. HCM is a particular genetic condition type of cardiomyopathy where they have a thickened heart muscle. But no, you can absolutely still have coronary disease and you can still have a calcium score. And
you're getting a lot of calcium score questions now.
Okay.
Someone said their coronary calcium score was 1,875. The stress test was problematic, but the angiogram showed only 2 times 30% stenosis in the right RCA.
Right. Yeah, that's right. Yeah.
How should this be interrupted?
So I would interpret that as non-obstructive coronary disease. So you've got disease, but it's not causing any blockages. And that means you should be treated aggressively with medical therapy. So working really hard to get your cholesterol down, particularly your LDL, working to get your blood pressure nicely controlled, so around 120 on 80, and doing what you can to improve, you know, your lifestyle, diet, making sure you avoid diabetes, and having any new symptoms reinvestigated.
Yeah. And how often should someone have an angiogram? So if the first one's been okay, how long would it take between them to become abnormal?
Yeah, so that's different for everybody. Angiograms come with their own risks. So we only do them if we think we need to put a stent in, or if we think that there's a narrowing. So generally you'll only do an angiogram if you've got an abnormal stress test or you've got really compelling symptoms. So we never do angiograms just to have a look and just check. So I would say to this particular patient that you would work really hard on preventing further disease or preventing progression with those factors that I mentioned, and any new symptoms should be investigated.
Thank you so much. Did you guys have anything else you wanted to think we've covered? Hopefully there's so much. I mean, I could talk to you guys about this forever, but obviously I'm conscious of your time, and I'm so incredibly grateful to you both. I think I want to let everyone know that both Ali and Monique, they've completely volunteered their time to be here to help raise education within the community, and it's such an important topic, and there's so much work that needs to be done to help try and reduce this stigma. And I'm just so grateful to you both for being a part of this, and to everybody for coming along. Thank you so much for kind of prioritizing your heart health and coming and chatting with us.
Thanks for having us on, Jen, and thanks for all the work you do. It's fabulous.
Oh, that's right. Thank you so much. Thanks, Ali.
Thanks, Jen, and thanks, Monique, for all of your information. And it was great that you put this together. I've learned something. So
good.
Good.
Great. Thank you so much, guys. And I'll be sending out a recording to everybody who signed up. So as soon as I can get to it. So thanks so much, guys. Bye. Bye.